Okay, thank you so much for having me here. So I'm going to, obviously you're getting the translation, hopefully. I'm going to talk, I was asked to talk about weight gain, which to be honest has been a really interesting topic in HIV medicine for about 4 years. So I want to first start with, when did we start talking about this? When did this question of weight gain in the setting of integrase inhibitors come up? Because we've had integrase inhibitors since 2008. That's when raltegravir came out. What is the current state of the knowledge on weight gain and integrase inhibitors? We have to talk about TAF with integrase inhibitors. What can we do about it? And then I need to end with the REPRIEVE study, because this was really a big event in HIV medicine. So remember, we got raltegravir in 2008. That's when it was first approved by at least the FDA in the United States. Then we got elvitegravir in 2012. Then we got dolutegravir in 2013. We got bictegravir in 2018, and we got cabotegravir, at least in places that are using it for treatment, in 2021. But when was this first event that happened that suddenly people started talking about weight gain? It really was at CROI 2019. It was a large analysis that was published in the NA Accord study, which is a large study across North America. And in that study, it looked that integrase inhibitors were associated with greater weight gain than protease inhibitors or NNRTIs. And in fact, specifically, dolutegravir, which had now been out for about 5 years, was associated with more weight gain than the earlier first-generation integrase inhibitors. And suddenly, we started talking about it, and it's been now almost 5 years that we've been discussing integrase inhibitors and weight gain. Now, at that same session at CROI in 2019, it was also important to notice that there is a general weight gain in the general population. It's not just people living with HIV. In fact, if you look across the planet, in Latin America, in the United States, in North America, in Africa, in Asia, there's a general increase in body mass index. There's a general increase in weight that's been occurring over the 21st century. But however, what was important to note is that weight gain is occurring more quickly and with a higher rate in those living with HIV than the general population. And so these overlapping epidemics of obesity, of cardiovascular disease, of hypertension, of diabetes, these are all occurring, especially in places like the United States, and especially in places of poverty in the United States, which is specifically in the South and Southeast. Food that is cheaper is more high calorie, and essentially there's been an increase in weight in high poverty regions. So if we saw that large observational analysis in 2019, it was really the ADVANCE study that focused in on the combination of an integrase inhibitor with TAF. The ADVANCE study was a large study to look at dolutegravir TAF FTC compared to dolutegravir TDF FTC compared to efavirenz TDF FTC in South Africa. And this was the first time dolutegravir was studied in sub-Saharan African populations. It was important to say that it was equal to efavirenz, which was the gold standard medication at the time, in terms of virologic suppression. But what was very notable about this study was that we saw weight gain that was increased in the dolutegravir TAF FTC arm, and that weight gain was more prominent for women. And in fact, this is data out to 96 weeks, but at AIDS 2020, the analysis went out to 144 weeks, and there was still a persistent increase. There seemed to be a plateau for women on dolutegravir TAF FTC of increased weight gain. So this was a very major finding in terms of the difference between efavirenz and dolutegravir in weight gain, and the difference was most prominent for women. Then a lot of analyses started coming out to look at the question of integrase inhibitors and weight gain. For example, this was a study that was done across randomized controlled trials of people living with HIV who are treatment naive, who are initiating ART between 2003 and 2015. This was published in Clinical Infectious Disease in 2020. And you can see that, again, it looks like integrase inhibitors in general as a class are associated with more weight gain than protease inhibitors. And the ones that's associated with the lowest amount of weight gain is NNRTIs. In fact, there hasn't been a convincing study that any NNRTI is associated with significant weight gain. And we'll talk later about the fact that efavirenz is actually associated with weight loss. So, and then of the specific protease inhibitors, integrase inhibitors, bictegravir seemed to be more associated with weight gain than dolutegravir. The order seems to be bictegravir, then dolutegravir, then elvitegravir, then raltegravir. So it's really bictegravir has the highest amount of weight gain. So one thing before we get to what can we do about it is what's the contribution of tenofovir alafenamide? Because I know that in across the planet, TDF is used, or tenofovir disoproxil fumarate, is used more commonly than TAF. But TAF is the #1 medication for tenofovir in the United States. So the United States favors tenofovir alafenamide over TDF, and in fact, BIC, tegravir, TAF, FTC is the most commonly used first-line therapy and second-line therapy really in the United States. This does not reflect WHO guidance, which of course the first-line regimen is dolutegravir, lamivudine, and tenofovir disoproxil fumarate. So what do we know about the contribution to weight gain of tenofovir disoproxil fumarate versus tenofovir alafenamide? Because it goes hand in hand with integrase inhibitors. So this was the OPERA cohort. This was actually just published in earlier this year in 2023, but the first results of this analysis was shown in AIDS Conference 2020. And this was a large study across the United States of individuals receiving care in the OPERA cohort, and the question was, what happened when people switched, when participants switched from TDF to TAF? And there was a large analysis stratified by the backbone agents of integrase inhibitors, NNRTIs, and boosted PIs. And you can see in this analysis here is that if you switched from TDF to TAF, let's just keep the anchor the same. You don't switch integrase inhibitor, you just switch from TDF to TAF. There was an increase in weight gain no matter what backbone you are on. If you're on integrase inhibitors, protease inhibitors, NNRTIs, switching from TDF to TAF led to an increase in weight gain of about 2 kilograms. And then if we just look at if you were on a protease inhibitor or an NNRTI before and you switched to both an integrase inhibitor and TAF, the weight gain was even higher. So there was an increased weight gain. There was a synergistic effect if you were switched to an integrase inhibitor and TAF at the same time. And you can see the relative contribution of each of the integrase inhibitors. Bictegravir was associated with more weight gain than dolutegravir, and at the lowest was elvitegravir. So I think this is really important because it suggests an independent effect of TAF on weight gain. And as an aside, if we looked at the DISCOVER trial is comparing in PrEP TAF FTC to TDF FTC. In the DISCOVER trial, there was weight loss with TDF FTC, and there was weight gain with TAF FTC. So that's as pure as you can get. There's no integrase inhibitor in there. Okay, so this was an important study that was actually presented, it's not yet published, at CROI 2023. Because this is getting to the question of what can we do about it? What can we do with integrase inhibitors and TAF and weight gain? And this was called the Characterize study, but it was actually taking that same advanced study, that randomized open label, non-inferiority trial in South Africa, and taking participants who were on dolutegravir, FTC, and TAF with an average weight gain over 96 weeks of 8.9 kilograms. This is very significant weight gain. And actually switching people back to dolutegravir, TDF, and FTC. So that was the design of the Characterize study, that at 52 weeks, participants could switch back from dolutegravir TAF to dolutegravir TDF and FTC. And the important results of this study showed us that switching from TAF to TDF, going back to TDF, led to a decrease in weight. In fact, there was a median weight loss of 1.6 kilograms. This is the first time we have seen an effect of taking away the TAF and going back to TDF with dolutegravir in terms of weight loss, first stabilizing weight, and then actual weight loss. This was just shown a couple of months ago at CROI 2023, and I think this will have implications for practice in the United States, where TAF is so frequently used. There were some other very important studies that were published, or at least presented, at CROI 2023 that have not yet found their way into publication. But if you want to summarize a lot of data put together, this is the current state of the field. In general, efavirenz seems to be an anorectic agent. We all used efavirenz. Efavirenz was dominated the field for so long before we switched over to integrase inhibitors. But efavirenz is likely associated with anorexia or weight loss. TDF is also associated with an anorectic effect or weight loss. So if you take someone on efavirenz, put them on dolutegravir, you're going to see weight gain. And if you take someone on TDF and switch them over to TAF, you're going to see weight gain. And the reason that efavirenz really got pinpointed at CROI 2023 is in the IDEA cohort, they actually had a large cohort that switched from nevirapine, TDF FTC, to dolutegravir, and there was no weight gain switching from nevirapine to dolutegravir. It was only the switch from efavirenz to dolutegravir that led to the weight gain. So that is really beginning to make us understand that efavirenz is associated with weight loss or anorexia. Then the question becomes, does it help to be on dolutegravir 3TC? If you are getting Devada and you're already using a lot of dolutegravir and 3TC in Brazil, then can you take away that TAF, and will that help with your weight gain? Well, there was a study that was presented at CROI but has now been published, which is a small single-site study in Amsterdam that looked at dropping the TAF. And it did show that there was improvements in cholesterol, and there was also improvements in lean trunk mass to drop the TAF. So this is the first time that we've seen an advantage of dolutegravir and 3TC alone in terms of weight. Why do I say this is the first time? Because I'm going to come back to this. The reason I say that is because the TANGO and the SALSA study, which were published in Clinical Infectious Disease in 2022 and 2023 respectively, actually looked at that very question. What if you were on dolutegravir, TAF, FTC, and you dropped the TAF? Actually, the TANGO study was you were on 3 to 4 drugs with TAF, and you dropped that down to dolutegravir 3TC. And the SALSA study design was switching from a 3 to 4 drug regimen to dolutegravir 3TC. Actually, TANGO and SALSA did not show an advantage on weight. Going down to dolutegravir and 3TC did not make you lose weight, but both studies showed an advantage in cholesterol parameters. So this Amsterdam study that I told you about is the first time that we've seen actually weight benefits of dropping the TAF. Now, your next question is going to be, well, What does it matter? Does this weight matter? Do INSTIs and the weight gain associated with them or the cholesterol effects increase the risk of myocardial infarction? And there have been some large studies that have looked at this. There was a study from the Respond cohort that was actually published in the Lancet HIV that did see an effect of increased cardiovascular events in the first 2 years of using INSTIs. However, a study that was shown at CROI of 2023 did not find that increased risk of using INSTIs and myocardial infarction rates. And in fact, these are patients who are essentially naive. So this first Lancet HIV study in the Respond cohort may have been a cumulative effect of having HIV for longer, being treatment experienced, but at least in a naive population, no increased effects of MI of the use of INSTIs. Okay, so this leads us to the last part of the talk, which is the Reprieve study, because the question is, what are we supposed to do about it? The Characterize study has suggested that switching from TAF to TDF will lead to weight loss. That is one possibility if you're on TAF. The Tango and Salsa studies may not have shown it, but the Amsterdam study showed us that switching to dolutegravir 3-TC will also help you lose weight. And maybe that's what you need to do to help with the weight loss. But what about other control of cardiovascular risk factors? And this was an important study. Of course, this was just published in the New England Journal. This is the Reprieve study. It was performed in the ACTG. And the question is, for weight, for decrease of cardiovascular risk beyond diet, exercise, what should we be doing to control cardiovascular risk in our patients living with HIV? So the Reprieve study was a randomized placebo-controlled study. And the question was, even if you have low to moderate risk of cardiovascular disease in HIV, is there a benefit of using a statin in those patients living with HIV? Because HIV seems to be an independent risk factor for cardiovascular disease beyond the effects of diabetes, hypertension, smoking, family history. There seems to be an independent risk of having HIV on increased cardiovascular risk. Why? Because HIV is a chronic infection. It's really associated with inflammation and immune activation. So the question is, adding a statin, which actually reduces very low LDL and also reduces immune activation, would that help with cardiovascular events? So the study design was people living with HIV between 40 and 75 years. They were all on antiretroviral therapy. 87.5% of them were virologically suppressed, and they all had low to moderate risk for cardiovascular disease as determined by risk equations by the American College of Cardiology and the American Heart Association. And the randomized study design was assigning patients to oral pitavastatin, doesn't matter what statin it is, but this is the statin that they used, versus placebo. And the primary outcome over a period of 5.1 years was a major adverse cardiovascular event. So there were 7,769 participants enrolled, half in each arm. The median age was 50, and 31% were women. And the median cholesterol, LDL, was not very high. It was 108, because these were low to moderate risk based on other risk factors. And the median duration of follow-up was 5.1 years. These results were shown in press release and then published in the New England Journal last month. The incidence of major adverse cardiovascular events was lower in the group that took the statin every day than those who took the placebo by a hazard ratio of 0.65. And LDL did decrease in the pitavastatin group, so that means people were taking it. And there was also a secondary outcome of incidence of major cardiovascular event or death at all, and the hazard ratio was still lower in those who took the statin. Now, I think this is what I'm going to show you next, I think is very important to think about statins in HIV. One thing I will say is that anything to the left of the line here favors the statin, And in subgroup analysis, the statin was favored. It always looked like the statin helped. But this is, I think, the most important finding from the study. And this is actually in the supplementary material in the New England Journal. If you look down in the supplementary material, it was actually those who were at moderate or high risk for cardiovascular disease that benefited the most from the statin. If you were at low risk for cardiovascular disease, the number needed to treat was very high. So I actually am more in favor, after seeing the REPRIEVE study, of really focusing on those who are moderate or high risk of cardiovascular disease. Maybe someday we'll treat everyone, but I don't think this study necessarily tells us that, and I think it's important to look at the supplementary material. So I'll end with INSTI seem to have an independent effect on weight gain. The combined with TAF, the effect is even larger. Efavirenz and TDF are anorectic. They make you lose weight. Switching from dolutegravir TAF FTC to the TDF regimen or dropping the tenofovir component does seem to help with weight. But the main thing is to control other cardiovascular risk factors. Right now, INSTIs are first line. We're not going back to efavirenz. And thank you very much for your attention.